we did discuss the evaluation using color flow Doppler evaluation of regurgitant lesions, and there are a number of things that we can look at when we have a regurgitant lesion, and the vena contracta is one. And we explained what the vena contracta is before, but the vena contracta is the narrowest portion of the regurgitant flow that occurs at or immediately downstream of the regurgitant orifice. And this is what we mean, is you have to have a very good understanding of the vena contracta. So if this is the so we talk, I mean, we're just talking about regurgitant lesion in general. So if this is, say, the valve, this is the valve plane, and regurgitation is going to occur right here. Again, remember that when you have regurgitation, it doesn't occur through an anatomic area. The regurgitation does not occur through an atomic area. The atomic area may be very big, but the regurgitation occurs through an effective orifice, regurgitant orifice. So, and it might just be like, this narrow. So when you have regurgitation, say at through this valve, then you're going to have the regurgitant jet right here. Regurgitant jet you're going to have down here. So let's call this RJ. So this is the regurgitant jet. Then right at the orifice, you're going to have a narrow area. This is the width and the area through which your regurgitation came. But right above the regurgitant orifice, you have this hemispheric flow convergence, which is set up when the blood or fluid rush down here. It sets up these hemispheric shells, and this narrow portion right here, the width of it is that's what we call the vena contracta. The area of the vena contracta is actually the EROA, which is the effective regurgitant orifice area. So again, the vena contracta is the narrowest portion of the regurgitant flow that occurs at or immediately downstream of the regurgitant orifice. Okay, it's like that. So the flow convergence. So the flow convergence so this is the flow convergence. These hemispheric shells. So they're not a complete sphere, they're half of a sphere, hence it's hemispheric. So the flow convergence is locating the flow convergence proximal to the regurgitant orifice. It's proximal, this regurgitant orifice right there. It provides qualitative information on both the location of the lesion causing the regurgitation and the magnitude of the regurgitant flow. So you can get qualitative information from this, and you can get quantitative. It can tell you how much regurgitation is occurring. So the three components that you need to know is the regurgitant flow, the vena contracta, and then the flow convergence. Those are the three components. you can get the flow convergence. Remember, when you do your color flow analysis of the regurgitation, on the sidebar, you have the color flow uh, uh, parameters that you can adjust. And we talk about the alias in velocity. Um, you want to adjust, you don't want to leave it at, say, 50 to 70 centimeters per second. You want to adjust it to get a nice hemispheric, uh, a nice hemisphere. So if it's not looking pretty or good, you adjust it, and we talk about a baseline adjustment, and we'll tell you what that is. So you want to adjust it so you get a nice hemispheric flow convergence. There are a number of other things that we can use. There are a number of other things that we can do with our regurgitant jet. And this is your color M mode. So you're gonna have to walk with me. So you have your ECG as usual. So you have your ECG, and you do your M mode, and you turn your color flow on. Now you know that blue. So you'll have your two-dimensional echo on top, of course, and blue means flow away from the transducer. That's why it's blue. Flow towards the transducer is red. So this flow right here, it's an MR, because when you put your cursor across the mitral valve, the blue suggests that it's moving away from the LV. So it's mitral regurgitation. But you can time the mitral regurgitation. This is ECG. Systole is from the beginning of the QRS to the end of the T wave. So this mitral regurgitation occurs throughout all the phase of systole. So we call it holosystolic. By definition, mitral regurgitation should be a holosystolic flow, but there are some conditions that can give you a late systolic flow or early systolic flow. Mitral valve prolapse is one of those things. But this holosystolic flow, you can get up on your color M mode, okay? Where you have this mosaic bluish color, tell you that it's mitral regurgitation, and then you just follow the duration on the ECG from the onset of the QRS to the end of the T wave. So it's holosystolic, as opposed to this one, the same setup, but systole is from the onset of the QRS to the end of the T wave, but you have nothing here. In early systole, nothing. The mitral regurgitation is all late systolic, and you can get this with mitral valve prolapse. And then let's look at this one as well. Again, your ECG is on top, your color M mode. You put your cursor across the mitral valve, and the blue color suggests you have mitral regurgitation, and the flow is away from the transducer. But when you do the duration, it starts at the onset of the QRS, but it doesn't continue to the end of the T wave. So this is early systolic. So you can use your color M mode to look at the duration of the mitral regurgitation. So especially if the patient have mitral valve prolapse, and you should do that. So the timing of regurgitation is important. So the duration and timing of regurgitation can be valuable in the overall assessment of the physiology and hemodynamics of regurgitation. While majority of the regurgitant lesions are holosystolic or holodiastolic, some may occur just during a brief period, as show you. Mitral valve prolapse is one of those things that can do that. So in mitral valve prolapse, the regurgitation may be limited to late systole and is rarely severe when it's not orthosystolic. Because remember, when we talk about severe mitral regurgitation, we're talking about a certain volume of blood going back into the atrium. If it's only a part of systole, then you might not get that volume. The volume is not going to be there to define severe regurgitation. So MR and TR may be limited by isovolumic contraction relaxation phase, particularly when you're talking about functional MR. Okay. So, but the time course of the regurgitant velocity, this what we call the spectral envelope, and that is the shape of the envelope. So the spectral velocity profile of a regurgitant jet. So, you know, when we talk about the spectral, let's just draw that so you have no. So if we, either mitral regurgitation or even, so if we're talking about, so we talk about mitral tract. If we talk about, so if we talk about, this thing is active. Okay. So if we talk about mitral or tricuspid regurgitation, the spectral envelope looks something like that, usually. But if we look at the semilunar valves, that's the aortic or the pulmonic, the regurgitant lesions or the trapezoid, it looks like that. So the spectral velocity profile of a regurgitant jet is determined by the pressure difference between the upstream and the downstream chambers with a parabolic shape, that's this, during systole for the atrioventricular valves and a trapezoid shape during diastole for the semilunar valves. And we know that, okay? However, for the AV valves, that's the mitral and the tricuspid, an early peak or cutoff denotes a large regurgitant volume. So if you get something looking triangular, the shape is triangular in, say, the TR or the MR, it usually suggests a large regurgitant wave, okay? And then when we look at, we usually say if the shape is triangular, it suggests severity. And then a rapid decay of the diastolic slope. So if we look at the AI or the PI, and it's very steep, this is very steep, then it's also a suggestion of severity. So, and you can look at your spectral envelope, and if you have premature termination of the diastolic flow, you get that in severe acute regurgitation. So, this is supposed to, if you have, say, AI or you have PI, it's supposed to occur throughout diastole. If it stops short, so you have your ECG to map this, and if it stops short, then it suggests acute severe PI or AI. So those are some qualitative things that you can do on all your valves, but more important is the quantitative assessment. So there are a few methods using Doppler to quantitate valvular regurgitation, and let's look at that. So we can when we look at a regurgitant lesion, there are a number of things that we can assess. We can assess the EROA, which is the effective regurgitant orifice area. So again, when you have regurgitation, it's not through an anatomic area, okay? It's not through an anatomic area. The regurgitation is going to occur across an effective area depending on the severity. If the regurgitation is more severe, then that EROA is going to get larger. So it's not a fixed area. Other things that we can look at is regurgitant volume per beat. Because if we say, for instance, you have mitral or tricuspid regurgitation, that is in systole, blood is going to flow back from the ventricle across your AV valve and into the atrium. So, and we're talking about per beat. So the more blood is going back, the more severe the regurgitation. And then the regurgitant fraction is basically the same thing. If the regurgitant fraction is getting larger, then the severity is getting more severe. So you have to understand the basic concept to fully appreciate this. So let's look at the mitral valve. So when you have mitral regurgitation, so if the mitral valve was not regurgitant, you'd have systole and all the forward flow would go across the aortic valve into the aorta. Nothing would go back into the atrium. And then in diastole, you'd have a certain amount of blood flowing from the left atrium across the mitral valve into the LV. Okay, you'd have a certain amount of flow. And that would be the same flow in systole that would flow across the aortic valve and into the aorta. When you have, say, mitral regurgitation, what happens is in systole, blood is going to go backwards. So blood is going to go forward across the aortic valve. Blood is also going to go backwards across the mitral valve into the left atrium. So in diastole, when you have the forward flow across the mitral valve, it's going to be what would be the normal flow plus the regurgitant volume that went back into the left atrium. So it's going to be larger than the normal flow across the other valves. And it's going to be abnormal by the amount of regurgitant volume that went into the left atrium. So if you calculate the forward flow across the mitral valve, and you can subtract from that the forward flow across the aortic valve or the LVOT, and you can subtract the forward flow from the LVOT or aortic valve from the forward flow across the mitral valve. The difference is going to be the regurgitant volume across the mitral valve. So that's a basic concept, and once you get that, then you know it's over. I mean, you fully understand. Okay. So we remember the stroke. We can look at stroke volume, and we have echo techniques, especially Doppler, to look at the forward flow across the mitral valve. So if we have mitral regurgitation, so in systole, blood is going to flow from the LV across the mitral valve into the left atrium, and then in diastole, we're going to get forward flow across the mitral valve, but that forward flow is going to be the regular flow plus the regurgitant volume. So we can calculate the forward flow across the mitral valve using the formula that flow is equal to cross-sectional area times the VTI. So all we have to do is calculate the cross-sectional area of the mitral valve and multiply it by the VTI or TVI across the mitral valve, and that will give you the forward flow across the mitral valve. We know how to calculate the forward flow across the LVOT. We've been beating that horse for a number of years. So the forward flow across the LVOT, when we simplify that, is 0.785 times d squared times TVI across the LVOT. So all we have to do is get the difference then, and we'll get the regurgitant volume. Okay? So let's show you how it's done. So again, stroke volume is equal to cross-sectional area times the VTI, and that's a stroke volume across any of the valves. In a completely normal arc, the flow across the mitral valve should equal to the flow across the aortic valve, should equal to the flow across the tricuspid valve, should equal to the flow across the pulmonary valve. It's a normal person, but again, we have regurgitation and we have even more severe regurgitation. So in a lot of situations, that's not the case. So stroke volume is cross-sectional area times VI. We're talking about the area. We assume that the area of these valves are circular. So the area of a circle is pi r squared, which is d squared over 4. And when you simplify that, pi is 3.14. So that comes out to 0.785 times d squared times VTI. Okay, and this is a stroke volume across any of the valves. Okay, d is the diameter of the annulus, and of course you have to pay attention to the units. It has to be in centimeters, and the VTI have to be in centimeters as well, and your stroke volume should be in milliliters. So we can calculate the stroke volume across the LVOT, 0.785 times d squared times the TVI across the LVOT. We can calculate the stroke volume across the RVOT as well. We can calculate the stroke volume across the mitral valve. So if you have any valve, any of the valves that is incompetent, you calculate the stroke volume for the incompetent valve, and you subtract from that the stroke volume of the competent valve. And the difference is the regurgitant volume. The regurgitant fraction now is the regurgitant volume over the stroke volume of the regurgitant valve. Straightforward. So when we're doing the stroke volume across the LVOT, we get the diameter, and we showed you how to do that. The diameter across the LVOT, parasternal long axis. If you're going to get the diameter for the mitral valve, apical 4-chamber view from leaflet insertion to leaflet insertion and diastole, and this is the diameter for the mitral annulus. For the LVOT, you do your pulse wave Doppler and you plane it, and you get the VTI across the LVOT. For the mitral valve, you look at the mitral inflow and your E velocity, A velocity. You plane the whole thing, and you get the VTI velocity time integral across the mitral valve. And you just plug the values in the equation. You can measure D, and then you can get the stroke volume across. So if you have mitral regurgitation, then the stroke volume across the mitral valve is going to be a larger number than the stroke volume across the LVOT. The difference is the regurgitant volume. So that's a straightforward. Okay. Then if you want to calculate the EROA from that, just bear in mind that, again, you have regurgitation across an imaginary area. Well, it's not an imaginary area, it's a real area, but it's a dynamic area, which will vary depending on the severity of the regurgitation. Again, let me just simplify this so that you don't. So we know that flow, which will be the regurgitant flow, regurgitant volume. Flow anywhere is equal to the cross-sectional area. In this case, the cross-sectional area is the EROA. EROA. And then times VTI. And it's going to be the VTI of the mitral. So if we use the mitral tricuspid over times the VTI, times the VTI. So, you know, so you can calculate this, you can measure this. This is the thing that you don't know. So the EROA is equal to the regurgitant volume divided by the VTI. So you can use Doppler to calculate regurgitant volume, regurgitant fraction, EROA. You can use it to do that. So this is using Doppler, but we can look at the flow convergence, and the flow convergence gives us additional additional means to calculate or to measure the severity of the regurgitation. So the flow convergence, as we showed you before, is just above or just at the regurgitant orifice. Is that hemispheric flow. I would call that the PISA, which is the proximal isovelocity surface area, PISA method. Okay, so you can to get a nice flow convergence, you adjust that color flow map. You do what we call a baseline shift. So if it's a transthoracic echo, then you move the baseline downwards. If it's a transesophageal echo, they have to move it upwards. So you're going to move it in an opposite direction to the regurgitation. Okay. So in MR with transthoracic echo, you're going to move the baseline because you want to get your nice. You want to see that color changing from red to yellow. Okay. The radius of the piece is measured from the Doppler aliasing to the vena contractor. So remember when we draw. So if this is the valve where you have the regurgitation, and then this is the regurgitant jet down here. Regurgitant jet. Oh, it's not a nice regurgitant jet. The one before was better. All right, let's erase that. Okay. So again, the valve through which you're having the regurgitation and the regurgitant jet is down here. Then you have the vena contractor at or below the regurgitant orifice. And then you have your hemispheric. So this is the flow convergence on top. Okay. So you're going to do your baseline shift to get your color changing. You want to see the color changing from blue to yellow. Okay. And the radius is you're gonna measure it from the vena contractor. So you're gonna measure the radius from here to there. Remember, it's an hemisphere. It's not a complete sphere. So it's half of a sphere. So the radius is measured from the vena contractor to the surface. And you do your baseline shift because you want to see the color change from blue to yellow. Okay. Okay. Now, as we pointed out before, this regurgitant flow, so flow is equal to cross-sectional area times velocity. We say that. So the flow, so if we're looking at this regurgitant flow down here, that flow is equal to cross-sectional area. That cross-sectional area is what is actually the EROA, because this regurgitation is occurring through this area right there, the cross-sectional area. So that cross-sectional area is EROA, effective regurgitant orifice area. And the velocity that we're talking about is the MR velocity or TR velocity, whatever. So that's the velocity. And this flow is equal to the flow convergence. The flow convergence, again, cross-sectional area, but this is an hemisphere. So the area of an hemisphere is 2 pi r squared, 2 pi r squared. Okay, so it's an excessive r. Okay, 2 pi r squared. And the velocity that we're talking about is the velocity that you shift on your color flow. So that's the Edison velocity. So you can see that on the machine. You can calculate this. The radius is this radius, you measure it. So the only unknown is your EROA, because you can look at your MR spectral velocity profile. You can get the velocity from that. So the only unknown is the EROA. So you can use the pizza method to calculate EROA. And then once you get the EROA, you multiply your EROA by the VTI and you get your regurgitant volume. And then you can calculate your regurgitant fraction. So you have to understand this method as well. So you can use the Doppler and you can also do it using the pizza method. So again, EROA, when you simplify it, is equal to cross-sectional area of the hemisphere divided by times the Edison velocity divided by the peak regurgitant jet. Okay, and then to get your regurgitant volume, the EROA that you calculate, you just multiply by the VTI and you get regurgitant volume. And if you want to get regurgitant fraction, then you divide the regurgitant volume by the volume across the valve. Okay. So the pizza method is simple conceptually, and in its practical calculation, it allows a qualitative and a quantitative assessment of the severity of the regurgitation, and it has become the main method of quantification of regurgitation, particularly of the mitral and tricuspid valve. So if you plan to do or to understand echo, you have to understand the pizza method, okay? Because this is what everybody use, and you know, you have to understand. So again, pictorially, the regurgitant jet is down here. This little area here is your the width of this is the vena contracta, and then this would be your EROA, effective regurgitant orifice area. This is the area, cross-sectional area, and then you have these hemisphere on the opposite side to where you're having regurgitation. This is the piece of radius that we're talking about. And then you do a baseline shift until you get a nice transition from blue to yellow. And then you can measure your radius. Okay? So this is an actual patient, and your baseline shift, and you can see there's this blue right there, this is yellow. So you're going to measure your radius from the vena contracted to the surface area right there. And then once you put your CW, you can get your uh, uh, velocity, regurgitant velocity. So this is how it's done, okay? So you should know how to do it. Okay, so while echo remains the first line modality for assessment of valvular regurgitation, so echo is portable, it's easy, it's quick to do. It may be suboptimal in some patients. In these instances, then cardiac MR can play a useful role because of a number of unique advantages. To be honest, cardiac MR is the gold standard. It's just that we can swing a MRI machine into any place. It's not very portable, it's not very convenient. The cardiac MR provides a view of the entire heart without limitations of imaging windows or body habitus, and allows free choice of imaging planes as prescribed by the scan operator. It's free of ionizing radiation. It does not require contrast administration. In addition, to assess the severity of the regurgitant lesion, a comprehensive CMR study is able to quantitate cardiac remodeling and provide insight. So really, cardiac MR is the gold standard. It's just that it's not readily available and it's not as portable and convenient as echo. So if you have the opportunity to learn about cardiac magnetic resonance, then you probably should. So let's stop here. On Thursday, we're gonna look specifically at mitral regurgitation. So we're gonna look at mitral regurgitation specifically, and we're gonna apply it. We should be able to go over that relatively easy because we already know what how regurgitant lesions behave. So we will just apply that knowledge to the MR and TR. Okay, so we're going to stop now. Okay, all right. All right, good night.